it is out there today. So like we said, I'm a family doc in Denver. I work at our family medicine residency training clinic through the University of Colorado. And we've been working on behavioral health integration for a long time. I also work, actually we've had a behavioral health provider in our clinic since the early 1980s when our clinic first opened. And it's been a part of our training, it's been a part of our clinical care delivery ever since. So I've been steeped in that culture. And then I'm also working with Barbara and others on the SIM project to help other practices integrate behavioral health within their communities and within their practices. So I'm going to talk through a few things today, and I'm going to leave some time for questions, both at the end of this session, but then also we're going to have a great panel discussion where hopefully it'll be an interactive chance for us to ask questions about what excites us about behavioral health integration, what gets in the way, and what are other ways that we can serve the behavioral health needs of our communities. So for this section of my talk, I'm going to summarize what is behavioral health integration. It's a large umbrella term that means a lot of different things to a lot of different people. We're going to understand that it's a continuum of services and not just one thing. Describe different ways that you in your own clinics and in your own communities can integrate behavioral health and medical services, and if you're interested, where you can go for help. So let's take a step back. We've been talking about, well, obviously behavioral health is so important, but why? So there's been a lot of research done about this, and it's not just a gut feeling that we all have. Health behaviors make a big difference to health and our well-being. Overall, over 40% of things that contribute to mortality and morbidity are caused by health behaviors, right? Only 10% is due to the healthcare system, right? Guess where all the money goes? Right? 90% of the money goes to the 10% of things that actually drive outcomes for our patients. So it's important as we start to shift, well, how do we actually take care of these other key factors in health? Well, we need to start thinking about how our healthcare system can engage in that, because that's where a lot of our resources lie right now. So why integrate behavioral health within a primary care setting? We've seen a few of these statistics already. I'm going to highlight a couple of them just because I think they resonate really profoundly with me as a primary care doc. One of them is down in the fine print, that 48%. 48% of all appointments for psychotropic agents happen not in psychiatry offices, but in primary care offices. 30 to 50% of referrals from primary care to outpatient behavioral health clinics never make it, not even once. And everybody's nodding their head, yeah, of course they don't make it because it's a pain in the butt. So how do we reduce not only the burden it is on the patients to make another appointment, take time out of their days, find childcare, get out of work, but also the stigma piece. That stigma piece that we mentioned a few times is real, that people don't want to park at a behavioral health center because people know their car. And they're going to know that they walked in that behavioral health center, so something's got to be going on with that, with Susie. The stigma piece is real. And then this last point, providers are struggling here. Primary care providers, over 2/3 of primary care providers don't feel like they can get the behavioral health services to the patients that need them. That's really hard when you ask a provider to do a job, any job, much less healthcare, if you ask them to do a job and you don't give them the resources to do it well. So behavioral health integration can help address some of those needs. Next, for those accountants in the office, it makes a difference to the bottom line. So of the top 10 most costly health conditions in the United States, almost all of them have a key behavioral health condition tied to them. Depression is number one. This is not just based on the number of times or the health insurance costs of going into an office or the prescription meds, but also what it means to the people when they're at home. Can they make it to work? If they're at work, are they actually productive? Well, we know that depression and other behavioral health and mental health issues erode people's ability to live their lives to their full potential. I'm going to try to let another person tell a patient actually tell his story about what behavioral health integration can actually mean at an individual level, because this is what we're really trying to get at. As a primary care doc, I love thinking about serving populations, but what is most rewarding is seeing an individual patient get better. And this is Patrick, who is a patient actually in Basalt, Colorado, who is served by a primary care doc who chose to integrate behavioral health clinician. Let's listen to his story.
I had the good fortune of 52 years, as I'm now 62, of what I'd consider to be perfect health. I was an athlete, always an athlete. I don't remember an injury. I didn't get sick much. And I had sold my business and I was prepared to become a competitive tennis player at age 52. And in a moment in time on a tennis court, I ruptured a disc into my spinal cord and partially paralyzed the lower half of my body. And then I become divorced. I don't really have a career anymore because I sold my company. I don't have a body anymore to speak of. And I'm broken. And I then go away for 4 full years. And so I took my isolation into alcohol and began to use it as my coach, my friend, basically, as any alcoholic will tell you. So as my life unraveled and I became to realize how broken I was, I didn't expect that my doctor would be the person that walked in, that I would open up to and break my isolation. As an MD, he's a straight line MD, and all of a sudden it's different. And after we do all of my vitals and we do this, he comes in and he sits down with a clipboard or with his computer and he says, okay, where are we going next? And we talk for 15 minutes about where I'm going next. And now after we go through my checkup, I see that the real appointment starts. Where are you? What have you done? Where's your training? Are you wearing? And he starts to go through a checklist that is well-oriented, not sick-oriented. 3 years into becoming empowered in my own health story and my own wellness, I was beginning to reach limits, and I started to lose some of the meaning of my own recovery program. I had stopped again. And when I sat in front of Glenn, and now my trust is, of these years of doing this, my trust is high, and I say, I'm afraid I can't go further. Where do I find the courage to go further? Here again, that moment when Glenn, instead of saying, no, you're doing great, he could have said that, and that would have been an answer that I would have believed. But he didn't. He said, okay, next, if you want the courage, I believe it lies in your behavior. So let's try some behavioral counseling. So working with a psychologist, being recommended by my doctor, so we were on point with what I needed to learn in order to move these programs forward. And fortunately, because I had a driving mission at that moment, the coaching was very direct, and it immediately broke open the underlying issues of why I had plateaued. And almost within a month of regular sessions, I felt I could see up again, and I started to move up. I've gone from a single bike path where I would fall off every 3 steps to now I feel like I'm navigating a 6-lane highway, and I have the group as my bumper guards. But I've got a 6-lane highway. It's up to me. I'm driving. I'm going. And they're there to make sure now that I don't fall off the outsides.
This is just one personal story of one person who was touched and whose health improved and whose life improved because of integrated behavioral health. I'm back. Good. So now let's talk about what is it? What are we actually trying to do? What did SIM is SIM trying to spread across the state? First, let's start with behavioral health. It's a little bit of a different term than what we're used to when we start talking about traditional mental health or substance use. And it's a broader umbrella that addresses any behavioral problem impacting health, including mental health, including substance use conditions, stress-linked physical symptoms, patient activation, and health behaviors. It's the job of all kinds of care settings, and while I'm focusing on how primary care can address this, it's done by all different types of clinicians, health coaches, and various disciplines of training. The actual integration of those services provides care resulting from a practice team of primary care and behavioral health clinicians working together with patients and families using a systematic, cost-effective approach to provide patient-centered care for a defined population. I read these because definitions are important here. Some people try to pigeonhole behavioral health integration to just depression screening or just substance use, and they miss a broader swath of what behavioral health can actually do for patients. It's really about meeting patients where they are. There is certain well-studied, well-thought-out, and well-described care models for mental health conditions like depression, anxiety, substance use, ADHD, autism. There's also behavioral health approaches for medical conditions, diabetes, heart disease, childhood chronic illnesses, and stress-linked physical symptoms, as well as for people with social and care complexity. Depending on what the needs are for your community, for your practice population, it can be very flexible in the ways that it can be applied. So, what does it look like? Most primary care practices who address this are going to use 3 different strategies in their setting. They're going to use consulting, coordinating, and collaborating as ways to frame their work. And this doesn't matter if you have a person on site or across town or in another county. These 3 C's can come into play, and usually there's a little bit of something that you can prove on, even if you're doing pretty well. So the consulting occurs when a clinician seeks advice, validates their care plan, says, do I have this right? Do I have the diagnosis right? This patient doesn't seem to be getting better with usual things. Am I on the right track? With another professional. Now that can be on site, it can be down the hall, it can be in the same pod, right on, if you guys share desks or pod space, or it could be on the phone or telepsych across the state, like some folks in Durango are doing with Children's Hospital around telehealth. Coordinating involves 2 professionals who have different plans, making sure those plans line up for the patient, and making sure those plans align with the patient's goals. And then finally, collaborating involves 2 or more professionals interacting in real time to discuss a patient's presenting symptoms, describe their views on treatment, and jointly develop a care plan. For those 3 C's to happen, organizations need to be aligned, and those relationships at an organizational level need to be developed and fostered. It can't just happen because 2 people want it to happen. Well, that's the nucleus of this. It needs to happen at a broader systematic change. So there's a spectrum, as you can see up here, of relationships at an organization that can help bring behavioral health services closer to your patient. And you can see all the way over at your left of isolation and mutual awareness. That's where most of us start. Yeah, I know there's a behavioral health person that's on the list of insurance that's taken by this person's insurance. Yeah, they're across town, but I don't know if I could pick them out in a grocery store. To cooperation, knowing and sharing resources between each other, maybe even sharing data or even space. Collaborative involves some joint planning. It steps up to partnership, where you're actually designing programs to work closer together as separate but coordinated entities. And then finally, merger, single organization, where under one roof, under one employer, lies both the medical health service providers and their staff, as well as the behavioral health system and their providers and staff. I would argue that moving the organization and the single organization isn't necessary, and in fact, sometimes it's counterproductive depending on your relationships with these organizations. So that's not the end-all be-all of what behavioral health integration has to look like. There's also relationships at an individual and personal level between staff members and providers of what it means to integrate. You know, there's the referral triggered. That's what we're kind of comfortable being in a medical system. You press refer in your EHR and you sign off and say, patient, you're on your way, and hope they make it. And then double hope that the information comes back that you were asking for. Those relationships can get better and this communication can get better with regular communication coordination. Either separate workflows, embedding it in health information exchange systems, or picking up a phone. And then full collaboration where the treatment plans are shared, documentation is updated by anybody involved with the care of that patient, and it ensures better coordination of care. So I love the article. You guys probably can't see this with the table. The article around describing what behavioral health providers can actually do within a primary care setting is called Dispelling the Myth of the One-Trick Pony. Behavioral health providers can do more than just screen for depression. Sometimes behavioral health providers, that's the first step into a clinic to show your value and to do it really well. But there's so many other things to do, including addressing psychosocial barriers to care. I talked to a psychologist who actually finally broke through with the provider when it was a pediatrician who was having a child have a tantrum about getting shots. And she said, you know, I'm trained to help children deal with stressful situations. Can I go in there? And the doc kind of gave him a squirrely eye and said, good luck, and did. And the child didn't even cry when they got the shots, right? So those small things make a big difference when you're talking about bringing teams together. Medical health problems, like diabetes, cardiovascular disease, these are all behaviors that people with skills like behavioral health providers have can deal with in ways that, as a medical provider, sometimes I'm limited, both in training and in time. Mental health and substance use, I think that's kind of where we're used to thinking about psychologists and other behavioral health providers being. But then there's also multi-morbid mental and physical health problems where you're not really sure what's causing that depression to be worse. You know, is it truly depression? Is it truly disease-related distress? Is it just really poorly controlled diabetes? And then severe mental health. All can be treated depending on the services and the skills of your behavioral health team. I'm going to repeat this again. These ideas of integrating behavioral health does not have to happen in one building. Many providers will never be able to have even one extra person in their office because they are bursting at the seams. There's not enough space for them. There may not be the workforce available to hire somebody to come there full time. Maybe your office is small enough that you don't have enough patients to keep that person busy. That doesn't mean that we can't do a better job addressing the behavioral health needs of our patients. The collaborative team approach is one approach that has been shown to help patients without having the person there on site. So just managing a population like with depression, anxiety, perinatal mood disorders, with a care team with a consulting psychiatrist and behavioral health people off-site and a care manager off-site can actually improve care as long as it's well coordinated. So you must be saying, well, Dr. Kyle, it's the right idea. It can work. It seems obvious, but why hasn't it happened yet? Well, I would say that a lot of this hasn't happened not only because of the systematic barriers, but because there's a cultural barrier between the traditional model and a new model of integrated primary care. Just pulling out some of the highlighting some of the difference between a traditional approach and integrated primary care. If you look at payment, usually in the traditional approach, it's separate. Two different billing organizations, billing fee for service for codes that only they can provide. Versus in an integrated model that works the best is when there's a global capitation, either capitation or global models or other advanced alternative payment models that offset, and not only offset, but pays completely for the services that patient needs. This shouldn't come off the backs of hardworking primary care providers or hardworking behavioral health providers to do it, to volunteer their services. The focus of care in a traditional approach is often provider-centric. Shifting that to a patient-centric approach that is delivered when a patient wants, where they want, by the people that they want delivering it, is difficult to achieve. Not only because of the momentum and the inertia that we have in the traditional system, but it takes a shift in our mindset and some deliberate thinking about what is actually best for a patient and what do they want. Not what do I think they want, but what do they say they want. This takes a lot of time. Now, let's say you overcome some of those barriers and you actually get a behavioral health provider to work really closely, maybe even in the same building, with a primary care provider. Well, these next two slides are actually from a psychologist who did just that. They came from their own private practice where this was very similar to their office. And they said, yeah, so this is what it's like walking into a psychologist's office. It's soothing. You have a nice window. You have 50 minutes to see a patient. Well, they came into primary care and felt it was like this. Right? Follow one motorcycle, and that's a patient in a clinic trying to get through.
Oh, here comes a big bus.
And this bus is the provider trying to get through their day. They don't care who's in their way, they're going to get through. And it's amazing more people don't get hurt. It's hectic coming into primary care. People are nodding, right? You come into work ready to hit the ground running, and you leave probably still with work to be done. It is hard to catch up and key in to actually the order that happens in a primary care clinic. You know, if you stopped and watched that traffic pattern, those people going through there knew what was going on. It was a pattern. People kind of understood the flow. But being a first timer, that's really hard to get used to. So there are common struggles that people have described when they try to integrate behavioral health. And what's awesome about this data is it came from right here in Colorado. Through the ACT study and the SHAPE study. How many of you are familiar with the ACT study, Advancing Care Together? One. Good. So this was a study that went on throughout the state with some very motivated, innovative primary care practices who said, yep, we're going to do it. And they allowed researchers in to see how they did it, understand the barriers, and try to problem solve. And they came up with 4 key struggles, but also many solutions to those struggles. Workflow and access to care was one of the biggest struggles that people commonly faced, that was made harder by new staff, part-time schedules, especially with getting people up and running. Usually people start with a day a week, a half day a week. It's really hard to understand, but it's addressed by expanding behavioral health hours gradually or sometimes even dramatically, allowing behavioral health schedules that give patient time, dedicated consultative time, but also on the fly. How do I grab somebody right when I need them at 4 o'clock on a Friday afternoon when they just said that they're suicidal? I need help then, so how do we allow for that? Increasing the bumpability, I love this word, the bumpability of the behavioral health provider. Not putting them in their office, closing the door, and then seeing them on their way out of the office, but getting them into the pods, next to the medical assistants, next to the nurses, by the phones, by the docs, to bump into each other, to say, oh, Dr. Jones, I see that you have Kathy there. I saw that she has ADHD and she's going back to school. Do you mind if I jump in there with her and her mom? Being there and asserting yourself by just being present is a big deal when it comes to workflow and access to care. Leadership and culture change. I talked to you about what that culture leap can feel like for a new behavioral health professional, where you might actually have differences in opinion, like how to perceive an illness. We're trained very differently in a medical model versus a mental health or behavioral health model. Both of those models have valid approaches, and it needs to be a mutually agreed upon and negotiated next steps when you bring both of those models together with the same patient. Oftentimes, it means finding the right fit, hiring for the right fit. Not every behavioral health provider was trained or is ready or even wants to deliver care in this setting. Sometimes it means saying no to the first person to find the right person. And many organizations that were successful in this, they will say they went through 4 or 5 behavioral health providers before they found the one that clicked with their clinic. It's not because those other behavioral health providers were bad people or didn't want this to happen, but there are different skills and different personalities that fit better in a primary care setting. The next struggle is following patients. First of all, defining a population that a behavioral health provider is responsible for, and then following to make sure that they improve is a big deal. How many of you guys work in a clinical practice who uses an EHR? How many of you have ever struggled making a change in your EHR? Oh my God, who's never had a struggle? I need to talk to you later and work at your clinic. It's really difficult to adapt EHRs to do this correctly. And oftentimes you have to take people's information and dumb it down a little bit and just use an Excel spreadsheet, right? Start somewhere and then build up gradually. Many clinics use these workarounds, whether it's registry systems, pen and paper. They put sticky notes on a chart to do this. But even those small steps are better than just top of mind. And then I like that the paper put this last, but I think this is first every time that you talk about what gets in the way of getting a behavioral health provider into your clinic. It's the cost. It's difficult to cover the costs in the current fee-for-service payment and carved out payment models. Many people have found ways around this, and there are new hope with SIM leading the way in the state, as well as the Comprehensive Primary Care Initiative and other multi-payer collaborative initiatives in the state that are actually paying primary care and behavioral health care differently than just fee-for-service. There's local community-focused solutions, expanding fee-for-service codes with individual payers. Rocky Mountain Health Plans has been a champion of that over here on the western slope. New advanced alternative payment models that I mentioned, as well as those models that incentivize quality over quantity. And many of the successful clinics plow those incentive dollars, those quality incentive dollars that they might have received for hitting diabetes or hospital readmission rates, they plow them right back into their behavioral health services because they've seen 2 things affect these quality and cost measures. One is care management, and number 2 is behavioral health integration. So they plow those cost savings or those shared savings or those reward dollars right back into their team because that's how they know they're going to continue to achieve these quality benchmarks. Keys to success. again, from many of the same practices in act and shape, people went out and talked to them and said, how did you succeed in integrating behavioral health? And these were words out of their own mouth. They framed integrated care as necessary to the care of their patients. It could not be extricated from their efforts to deliver patient-centered, whole-person care. There was no other choice. You burned the bridge. They defined relationships and protocols up front so that people understood where they were going, but also that things were going to evolve once they knew more. So they said, we're going to try this, and then we're going to revisit this because we know it's not going to be right, and we're going to make it better. Then they built inclusive, empowered teams to provide the foundation for integration. They found local champions. They didn't go to Dr. Paul, who doesn't want to do this, didn't ever want to go to an EHR, and is very reluctant to make any changes. They didn't go there first. They went with the easy wins, the people who already wanted to do it, the front desk staff, the nurse, the new grad coming into the clinic who didn't know what their job was supposed to be anyways, and they said, this is you. Then they developed a change management strategy for continuous evaluation, knowing that whatever they did wasn't the right way to go, that they could always improve. And by admitting that they weren't perfect and that they wanted to improve, they created this culture of, yeah, hey, why don't we try this today? Why don't we try that tomorrow? Man, last week was really tough. What went wrong last week that we should never do again? And then they used targeted data collection that was pertinent to integrated care to drive improvement. Because they knew that it wasn't just going to be the gut reaction of the people in the clinic that was going to propel this and prove to others that it was a good idea. They needed hard data. Now, that hard data didn't have to be clinical quality measures. It wasn't always total cost of care, because how many of us can actually get total cost of care that we trust? It could have been, how many people did we screen for depression? And what were their PHQ-9s 9 months later? It could have been, how many people did we screen for developmental delays? And how many of them did we actually get early intervention results back from our local ABCD group? By showing that behavioral health made improvements on those real tangible things, and not only created buy-in amongst their team, but also showed to external stakeholders that, yeah, this is a good idea. All right. Hopefully there are some of you out there that came to this meeting because this is what you wanted to do. That you wanted to support behavioral health integration in your own clinic or in your own community, or engage primary care practices who are along this path. So now what do you do? So being in Colorado right now, you have the blessing and the curse of so many resources out there to support your practices and your communities, that sometimes it's like a kid in a candy shop and you walk out with a stomachache because of all the things to choose from. There are many programs that build on not only the foundational skills necessary to integrate behavioral health, but also some of the advanced topics like SIM achieves, or some practices in transforming clinical practice initiative are achieving. All of those are available to practices across the state. And there's dozens of more programs specifically targeted at local communities. And we've created a catalog of those resources on our website. So this is oriented for primary care practices, saying, where do I go for help? You can go to this catalog.practiceinnovationco.org. If you know what you're looking for, you can sort and filter really quickly. If you don't know where to start, you can do a quick 10-minute self-evaluation of where your clinic is and find programs that address your key gaps. We talked about the state innovation model. I'm really excited that many of you have applied for cohort 2. We hope that your practices get in because there's a lot of resources there for you. In 2 years of support, you can make some great strides with the coaching and other resources available. For those of you who weren't quite sure of cohort 1 or cohort 2, there's a cohort 3 application going to be coming out in the next several months that you can keep an eye out for. And as Barbara mentioned, there are more ways than just getting your primary care practice engaged and enrolled in a cohort of SIM. SIM supports much more than just primary care. And you can see that while the first cohort definitely has a Denver metro area focus, because that's where a lot of the applicants came from, it is spread out across the state from LPHAs, community mental health centers, behavioral health treatment centers, and regional health connectors that are available in every corner of the state. There's Transforming Clinical Practice Initiative that is available for any provider of any specialty to actually get coaching and join learning communities of peers who are trying to make changes. Not everybody is working on behavioral health, but many are. And in fact, many of our mental health centers are joining up, and joining the learning community with them can be helpful. Let's say you're a do-it-yourselfer, though, and you don't want to actually have somebody come into your practice yet, or maybe you already have coaches, and you just say, hey, where can I find out some more information? There's a lot of great resources out there. We're going to share these slides so you can use these. But the Agency for Healthcare Research and Quality, ARC, has an integration academy. And they have a great playbook that walks through, hey, starting from scratch to being a fully functioning integrated care team, here are some resources and best practices. We have a resource hub through the University of Colorado's Department of Family Medicine, where I work, that has curated hundreds of resources and dozens on behavioral health integration. Practical tools that practices have said, yep, I've gone here, I've used these resources, and it's helped me. You can go there to find out more. And then the University of Washington's AIMS Center is at the forefront of looking at the collaborative care model that I mentioned briefly. You can go to their aims.uw.edu for more information for different models of delivering this type of care. So we'll get there, steps at a time, but we'll get there. And I'm really inspired by many of the practices that have overcome these barriers in your own communities that I've talked with, as well as around the state and the country, to serve their patients better and serve their communities better. So thank you guys for your attention, and be happy to take any questions or comments. Good. Yeah, so it was a perfect question about how can providers, medical providers, introduce this concept of integrated behavioral health so that patients actually want it? And the first thing to say is that don't call them psychologists. Because they're like, why do you want a shrink to see me? Do you think I'm crazy, doc? I learned this actually from an integrated health provider, Sandy Mont, who runs a training over at UMass for behavioral health providers to get trained in this integrated model. And he says, introduce them as experts in the patient's problem. So I love it because I actually use this. If the patient says, if the patient is saying, I feel really stressed right now and I can't sleep, my response is, I have an expert in sleep and stress right down the hall. Do you want me to bring them in? And they're like, oh, you do? Right now? And I say, yeah, they can work with you on stress and sleep, and never once say their degree. Or, man, yeah, I'm just feeling really down. I'm feeling really depressed right now. Well, I have an expert on depression. Do you want me to bring him in? Gosh, doc, I feel like I'm drinking a little bit too much. I'd like to cut back. I have an expert on people making hard but healthy lifestyle changes. Can I bring in a health coach for you? So those words matter to my patients, and it seems like using the word expert, because that's what you are, that's what these people are, helps them kind of break down that stigma. If we don't have questions, I am interested in your guys' stories. We're going to get to this a little bit in the panel, but maybe we'll start it now. Can somebody tell their story about addressing the behavioral health needs of your patients in your community, in your practice, and how it went? Who has tried to do behavioral health integration better? Whether it's just coordinating with a neighboring provider that you know, or if it's actually bringing somebody in on site. So I firmly believe that there are more experts in the audience than on the stage right now. Yeah. Can I bring you a mic?
This will be a story and a question. So I'm Jeremy. I'm the CEO of River Valley Family Health Center in Montrose and Olathe. We've been working with the Center for Mental Health for years with integration. So originally we started at co-location. You know, they were kind of down the hall and they were down the hall. We started really integrating them in our pod environment where we would ask them to, hey, let's come out of your traditional therapy, come hang out with us in the pod so we can use you for the warm handoffs. And we've continued to move down that path. And our quality metrics are the best they've ever been. Again, measuring the cost associated with that is difficult, as you mentioned. And so we're still trying to collect that data. But now, this goes to more of my question, is I'm not sure really what we're thinking, but we're going to do the opposite. We're actually going to move into the center's building and bring primary care and dental care into a traditional therapy room. So Laura and I both laughed when you had those videos up because we're going to do the reverse. So we're going to bring in the very stressed, very high intense primary care setting into a traditional therapy office that has how many therapists in there? 9? 4 or 5. So we're going to bring in 2 primary care providers, a dentist and a hygienist into their space. So with all of the research we've done, I haven't seen a lot out there associated with that, and we work constantly on how we're going to integrate that better. I would say right now we're probably a level 4 integrated care. We would like to get to 5 and 6. But we're struggling with what that's going to look like and trying to prepare them for the invasion of stress and our patients and all of that. The goal is obviously the patients. You know, a large percentage of their patients don't have primary care. So we want to be there to serve their patients. And a large percentage of our patients won't go to the center to get care. So if they're going to come to us to get care, well, now they're in our pod and they're down the hall. So we think that's an appropriate model, again, to do that reverse direction of care. But I haven't seen a whole lot of other models surrounding that as far as the success and honestly, what are those terrifying things in the corner that we haven't thought about yet?
So you're exactly right. That is at the frontier of being patient-centered for these patients with who do see their medical home as the mental health center. So excellent that you guys are thinking about that. Colorado now with their 4 integrated. I'll stay put. I was told to stand up at the podium. So Colorado, with their 4 bidirectional health homes, may be probably the best resource in the country when it comes to doing this. Now, some of these mental health centers have partnered with local FQHCs to provide the providers. Others are hiring them on themselves, so there's going to be a learning community about what works best. I'd be happy to put you in touch with some of those people because you're right, there's not much literature on it. There's not many big research studies that have kind of the core points of do this and please don't do that. So probably it's going to be talking to the people around the state that are already trying it. Oh, yeah.
So of the 4 bidirectional health homes, 3 are specifically focused on the serious and persistent mental illness clientele, but 1 is focused more on the less serious mental ill population that might be seen in the community mental health center, and so that would be the Jefferson Center model. They would be worth reaching out, and they still partner with an FQ, bring that primary care provider on site, but they're not just targeting that specific SPMI population.